Tait. I'm a third-year cardiology fellow, and I will be presenting a case of right ventricular lead perforation and cardiac tamponade. I have no relevant financial disclosures. Approximately 200,000 cardiac pacemakers are implanted in the United States every year, and these do carry a short-term complication rate of about 12%. 0.1 to 0.8% of these are due to lead perforation. Majority of these cases do not develop hemodynamically significant pericardial effusions, but if they do, they must be recognized quickly as there can be catastrophic consequences. Historically treated with open surgical drainage and revision, but these select patients may benefit from pericardiocentesis and only require minimally invasive lead revisions. So we present a case of a 73-year-old male with a history of paroxysmal atrial fibrillation and tachycardia bradycardia syndrome who was seen in the cardiology office for routine follow-up after a dual-chamber pacemaker was placed 6 months prior. On device interrogation, the patient did have evidence of lead dysfunction and dislodgement, and he was scheduled for lead revision. He did undergo 2 lead revision, which was uncomplicated, and patient was discharged home. The following day, he did present to the emergency department with chest pain and shortness of breath, and stat echocardiogram demonstrated a new moderate pericardial effusion. There was no evidence of hemodynamic compromise, and patient was treated conservatively and monitored on cardiac telemetry unit. However, the following morning, patient did have worsening shortness of breath, tachycardia, and hypotension, and patient was found to have tamponade physiology on repeat stat echocardiogram. Patient was taken emergently for pericardiocentesis with drain placement and monitored in the intensive care unit. Later that evening, patient did have increase in hemorrhagic output from his pericardial drain, and concern for lead perforation was present. Patient did have chest x-ray performed, and ultimately a CT scan of the thorax, which confirmed the right ventricular lead penetrating through the myocardium and pericardium. Due to this, patient was stabilized with minimal output from the drain in the intensive care unit, and hospital day 4, he did have successful lead revision in the electrophysiology lab. Patient was then discharged the following day with transthoracic echocardiogram showing no evidence of pericardial effusion. So although still rare, it is a well-known complication of pacemaker implantation, and it can result in significant morbidity and mortality if not discovered early. The incidence of lead perforation may be underestimated due to a large percentage of asymptomatic cases, but when present, chest pain, dyspnea, pacemaker malfunction, and cardiac tamponade and death can be present. Multimodal imaging should be used for confirmation of the lead perforation, and pericardiocentesis and minimally invasive lead revision is an option for select patients not necessarily requiring open surgical repair. Absolute risk factors for developing lead perforation are not entirely known, largely due to the low incidence of cases, but multiple reports suggest women, kind of elderly, and low body weight all risk factors for lead perforation. Device characteristics such as implantation of the ventricular lead in the RV apex or free wall carries a higher risk than implantation in the septum. And finally, reports have shown incidental finding of as many as 15% of pacemaker leads demonstrating radiographic evidence of perforation, and these asymptomatic cases can largely be managed conservatively.